I would like to thank CSI to invite me for a lecture. So I remember the days when I was sitting there organizing some conferences for Lari Cardiology. Now it's my privilege to present a lecture here in front of my teachers, Dr. Kapoor and Dr. Divedi. So I'll not take much time. I'll straight away go to the approach to a patient of paroxysmal AF. AF is a very big topic, but I'll try to summarize and finish it off. So to introduce, atrial fibrillation is the most common arrhythmia which we see in clinical practice. It is a significant morbidity. Occurs more in males, incidence increases with age. There is 3 to 6% of acute medical admissions. It increases the cost by 5 times. So the global prevalence of AF, India comes under the moderate range. There are multiple risk factors, most commonly being the aging, genetics, ethnicity, and male sex. So coming on to the definition, the newer definitions say the AF is either first diagnosed, which was not diagnosed first, paroxysmal AF less than 7, either cardioverted or not cardioverted, persistent is 7 days to 1 year, more than 1 year, and we are still planning for rhythm control. It is long-standing persistent, and once we decide that we are going to do rate control irrespective of the AF, then it's a permanent AF. So coming on to my topic, paroxysmal AF, it is the most common. 25 to 62% of cases are usually paroxysmal. May be underestimated the incidence because it is asymptomatic most of the times. The underlying causes are usually similar to persistent AF. However, in paroxysmal AF, there is no underlying cause in nearly half of the patients. Patients are younger. Hypertension and CHF are less common. LA size is smaller and LV systolic function is better. 25% of paroxysmal AF patients eventually become persistent or permanent. And 25%, as I told, what is the reason for progression is either atrial structure remodeling or the worsening atrial cardiomyopathy. The risk factors are same like age, heart failure, hypertension, CKD, and so on. So there is a new concept of AF burden. Now AF burden is defined as the overall time spent in atrial high rate episodes or a subclinical AF during a specified monitoring period, either 1 day or 1 week. So the higher the AF burden, it has been shown that the more cardiovascular mortality, morbidity, and heart failure is being seen, and the greater amount of the total AF burden, and mind you, it is not the longest AF episode which is important. It is the total AF burden over prescribed time which is more important in determining the thromboembolic event rates. And this, the higher the AF burden, the less chances of the patient to come back to normal sinus rhythm. So according to a trend study, the presence of more than 6 hours of AF per week, especially progressing to more than 24 hours per week, has been associated with increased mortality to more than 3 times, especially in women. And so comprehensive management of the modifiable cardiovascular risk factors and the comorbidities reduces the AF burden. Now coming on to the management, we have a ABC pathway to patient management. Going on according alphabetically, the first thing is anticoagulation. B is better symptom management by rate and rhythm control. And C is the cardiovascular and comorbidity optimization. So coming on to the patient of paroxysmal AF, how do we approach? So the first thing, as everyone has pointed out, is a clinical history, a detailed clinical history. And we have to identify the cause because there are multiple reversible causes of AF. So what we see is that anemia, infections, renal function tests, serum electrolytes, cardiac enzymes, and so on. Anticoagulation, before that we have to see whether the patient has a structural heart disease or a normal heart, CHA2DS2-VASc scoring, renal and hepatic function, and CBC. For rhythm control, we have to see a symptomatic AF. Now the problem is that they are intermittently symptomatic, so we have to correlate the symptoms of AF with a Holter. Whether the patient choice is rhythm control or no, usually they are younger, first episode, short history, tachycardia mediated cardiomyopathy, we need to do rhythm control, limited atrial remodeling, there are multiple things. So rate control, we need to take a proper history of the background therapy, whatever they are taking, what are the symptoms, whether they have taken rhythm control before or no, whether they have hypertension, heart failure, COPD, because we need to check what drug we need to give them. So this is the history, what we have to take in these patients and the investigations. So coming on to the A, I'm not going to take much time in antithrombotic as it's a very common topic. Thromboembolism risk, as we all know, is very, very important in patients of persistent as well as paroxysmal. And it has been shown that thromboembolic events and stroke rates are higher in persistent AF as compared to paroxysmal AF. And the therapeutic options which we have available is the vitamin K antagonist, the NOACs, the LA appendage device closures, and the surgical left atrial appendage exclusion. So the decision regarding long-term anticoagulation is based on stroke risk factors and not on the temporal pattern on AF. So this is the CHADS-VAS score which we usually follow, which tells us the stroke risk per year. It has a score of 0 to 9 and the stroke risk of 0 to 15.2. So as we see that the risk initially is lower, but later on it doubles. So coming on to patients, how do we start anticoagulation? So first thing and the most important thing is structural heart disease. Structural heart disease means either a prosthetic mechanical heart valve or moderate or to severe mitral stenosis. Rest others go under CHADS-VAS. If this is yes, we don't have any option. We have to give a vitamin K antagonist until the further trials come. And the therapeutic range should be, TTI should be more than 70%. If the CHADS-VAS score is more than equal to 1 in male or more than equal to 2 in female, then we come down as if it is 1 in male or 2 in female, then we say it's a 2A indication of a OAC. And if it's more than equal to 2 in male and more than equal to 3 in female, it's a class 1 recommendation. LA appendage closure is still under trials, and it is a 2B indication where patients cannot take long-term oral anticoagulation, and aspirin is not recommended either alone or along with anticoagulation in patients with just AF. Coming on to the rate control, now the rate control has been given a bit leniency, and now we keep it at less than 110. However, less than 80 should be kept in patients who have persistent symptoms, deterioration of LV function, those who are on CRTs, and increase in heart rate during exercise. It should not increase by more than 25%. And the therapeutic options are calcium channel blockers, beta blockers, amiodarone. So coming on to the comorbidities, if the patient is having a normal heart, we can give either beta blocker or a calcium channel blocker. Reduced ejection fraction, beta blockers are preferred. Severe COPD or asthma, calcium channel blockers. And if it's a pre-excited AF or atrial fibrillation, always catheter ablation is preferred. If it is not being controlled, we can use a 2-drug therapy or a 3-drug therapy, and we have to bring down the patient to less than 110. Coming on to the rhythm control, if symptoms are attributable to a paroxysm of AF and the factors favoring rhythm control are present, it is always important to do a rhythm control because it goes on to improve the quality of life. But it does not only require rhythm control, it is actually a combined work with stroke prevention strategies. The rate control is very important, and the cardiovascular risk reduction is very, very important. So this may reduce the rate of AF progression, and the most important thing is the modifiable risk factors have to be removed. The modalities which we have are pharmacological, electrical cardioversion, catheter ablation, and surgical closure. So coming on to the flow chart, if the AF is hemodynamically unstable, we have to decevert. If it's a hemodynamically stable, if it is less than 48 hours, we have to do early deciversion. If it is more than 48 hours and the patient is hemodynamically stable, we would like to give at least of 3 weeks of oral anticoagulation. But if the patient is too much symptomatic, we do a TE, rule out a LA thrombus or a LAA thrombus, and give a cardioversion. And more than 3 weeks of anticoagulation is actually recommended more in patients those who have a previous history of thromboembolism, moderate to severe MS, or a prosthetic heart valve. Giving cardiogenic shock, short-term OACs, even those patients who have a CHADS-VAS risk of less than 1, even then the 4 weeks of short-term, 4 weeks of OACs has been recommended. However, if the duration is less than 24 hours, it's optional. So the drugs which we have for pharmacological, if it's a normal heart, we can use amiodarone, flecainide, propafenone, but it's a structural heart disease, we cannot use flecainide and propafenone. Pill in the pocket, it is a selected outpatients, those who are very, very educated, and it needs to be actually checked in hospital. It is dangerous if it is taken 48 hours after patient has a AF and multiple frequent doses, and needs to be actually combined with a beta blocker or AV nodal blocking agent. Catheter ablation has been shown to be successful, and it is more in patients who are symptomatic with paroxysmal AF and those who are intolerant or not responding to antiarrhythmic therapy. So what we see is that a patient, we have to see the choice. If the patient wants, then we do a catheter ablation. Otherwise, we go in for drugs. Now, the cardiovascular risk control is very, very important in the form of sugars, hypertension, physical activity, OSA, alcohol has to be reduced, smoking has to be reduced. And surgery is seen as those who do not respond to either catheter ablation or antiarrhythmic drugs. Thank you.
Thank you very much, Dr. Saran. That was just on time.